Hi, a very good morning. Thank you to the moderator for the nice introduction. I'd like to thank the organizer of the Sarawak Urology Department for inviting me to speak in this BUU 2021. So I'll be talking about prostate cancer from diagnosis, screening, all the way to staging. So I have no disclosure for this talk. The content of my talk will be the introduction, screening, diagnosis, as well as staging for this disease. So for introduction, why do we need to talk about prostate cancer? As you can see in the data of Global 2020, the global data, prostate cancer is the fourth most common diagnosed cancer worldwide, and it's the eighth most common cause of death worldwide for among the malignancy. How about our Malaysia data? So fortunately, prostate cancer is not that common in Malaysia. It's the seventh most common cause of newly diagnosed cases, and it's the 13th most common cause of death among malignancy. So as you can see, our data compared to global data, we are still not that common compared to the other form of malignancy. So what's the risk factor? There's actually three important risk factors that is associated with prostate cancer. First is the age. The older we are, the highly likelihood that we're going to get prostate cancer. And geographical also play a very important role, seems to have more in the Western countries, less in Asia. There's actually a data that followed up a group of Japanese men. They actually migrated to Hawaii and realized that actually the number of prostate cancer diagnosis among this group of Japanese men actually approached the Western countries. And surprisingly, mortality rate is actually highest among those who is African descent. Family history also very important. If there's family members with prostate cancer, the risk of having prostate cancer is higher, especially those with germline mutation, especially in DNA gene. Other comorbids such as metabolic disease, alcohol intake, dairy intake, tomatoes intakes, these have contradicting evidence and association. Some actually reduces the risk, some increases the risk, but there's no strong evidence to link any of these to prostate cancer. Right? So next I'm going to talk about screening. First, we talk about population screening, and this is a PSA-based population screening. So what do you mean by population screening? Technically, this is a systemic examination of asymptomatic men. That means we take men without symptoms, and then we just screen them based on PSA to look for prostate cancer. Why? So why do we do this? The aim is actually to reduce the mortality as well as to maintain the quality of life. Okay, do we still do this? Well, it's actually still controversial. The earlier studies actually shows that this widespread aggressive screening actually associated with reduction in mortality. But recent evidence in the past 7 years shows that, well, screening do increase the diagnosis, reduces the risk of advanced disease being diagnosed, but overall there's no increase in, no improvement in the prostate cancer survival benefit as well as the overall survival benefit. So instead of doing the overall population screening, we probably go towards this individualized risk-adapted strategy. So we identify men with increased risk, and then we provide adequate counseling to screen these patients. The objective of this is to maintain the balance between over-diagnosis as well as treatment against survival benefit. So we do not subject all men to PSA testing without counseling them of the potential risk and benefit. And usually we offer this to those with life expectancy between 10 to 15 years. So as you can see, those with risk include those with 50 and above, 45 with family history of prostate cancer, African descent, as well as those with BRCA2 gene. During counseling, it's very important for us to tell them this. By doing this PSA-based screening, we actually increases the diagnosis, increases the early cancer detection, and less advanced cancer detection. The survival benefit, though, is not proven. Probably we need study which is more than 15 years to see the potential benefit. So probably it's not suitable for patients that you see the life expectancy is less than 10 to 15 years, because we need to balance this against the risk of over-diagnosis as well as over-treatment and the related harm. And also it's important that all treatment has some amount of impact on the quality of life. So we need to decide about that. So how do we do this PSA screening? Mainly it's through digital rectal examination and PSA. If it's abnormal, then we proceed with diagnostic. If it's normal, then for risk patients, we can screen every 2 years. Who are not at risk, we can screen up to 8 years later. So who are these not at risk? Mainly they are normal digital rectal, no family history, no African descent, no germline mutation, and the PSA is very low to begin with. Those less than 1 at 40 years or less than 2 at 60 years. The reason why we choose 8 years later is because there's a study that proves that even 8 years later, when they follow up this group men, the risk of them developing malignancy is actually less than 1%. What other potential tool do we have, but it's not proven? We have MRI prostate. These two studies is studying the potential benefit of using MRI to screen for prostate cancer. We can use some urine and serum biomarkers or even risk calculators such as the two provided here, the PCPT cohort or the ERSPC cohort. So none of this is still proven to be beneficial. So this is probably in the pipeline in the future. Remember, I talked about life expectancy. So how do we actually determine the life expectancy? We don't have a one-size-fits-all tool, all right? So especially in geriatric population, we look at all these tools that we can use to aid us in diagnosing. So we can use the geriatric age screening tool, as you can see on the top, on the right bottom corner. Then we have the CISRG, which is the top right corner. Then we have Charlson Comorbidity Index, mini COG, cutoff score, ECOG score. So we use a variety of tools to help us determine whether this patient will potentially survive more than 50 years before we decide on screening. Next, I'm going to talk about diagnosis. There's no specific symptoms that's related to prostate cancer, all right? So some of the potential symptoms include lower urinary tract symptoms, things that we commonly see among BPE patients, hesitancy, poor flow, terminal dripping. Some patients may actually present with hematuria, bone pain, or even neurological disability. And during examination, usually when we examine, we do a digital rectal examination. You can see nodular, hard, craggy prostate, loss of median sulcus. Sometimes they have bone tenderness, that's bone metastasis. And finally, we will do a PSA. And usually in prostate cancer, the PSA would be elevated. But there's a caveat on PSA. PSA is actually organ specific, it's not cancer specific. So it's not necessary that elevated PSA is 100% prostate cancer. So we need to be careful on this, and there's no agreed definitive cut-off PSA level to diagnose prostate cancer because PSA can be elevated at 6, 7, but the patient probably has prostatitis or just benign prostate enlargement. But from this table, you can see the higher the PSA level, the higher the likelihood of prostate cancer. So the most widely acceptable cutoff for prostate cancer we use is actually 4 nanogram per ml. But remember, there's a group of patients who will be on 5 ARI. So in this group of patients, we need to monitor their baseline. So they probably maybe have a PSA of 3 to begin with. Once they start on 5 ARI, the PSA go down to maybe 1.5. So remember, this baseline as a 1.5 is the new baseline. And any elevation following that, you probably have to screen for prostate cancer. There are some aids to help us improve the specificity for prostate cancer diagnosis based on PSA. One of it would be PSA density, where we divide the PSA to their prostate volume. So anything more than 0.15 nanogram per ml, the higher risk of prostate cancer. If the PSA level falls between the level of 4 to 10, we can also use the free to total PSA ratio, where anything less than 0.1 has 56% increased risk of prostate cancer compared to those with more than 0.25. There's also other things that we can use, such as biomarkers. We have serum biomarkers, such as prostate health index, the 4K score, ISO-PSAs. We also have urine biomarkers, such as PCA3, select MDX. These biomarkers are not widely available at this moment, but if it's available, it can actually help us to identify patients who has increased risk of prostate cancer compared to those who has less risk of prostate cancer. Risk calculators are the one that I mentioned earlier, so we can also use those calculators to help us to decide whether this patient has increased risk or reduced risk of prostate cancer. Commonly now, we actually have imaging to help us to diagnose prostate cancer. The standard transrectal ultrasound is still not reliable. There are increasing new technologies such as micro-Doppler ultrasound, high-resolution micro-ultrasound to help us to gain the image of the prostate to decide whether this patient has risk. But the commonly acceptable use now is actually multiparametric MRI of the prostate. It has very good sensitivity, good specificity to detect clinically significant cancer. So this can potentially help us to re-stratify patients to avoid unnecessary prostate biopsy. So based on the EAU recommendation, we do not use MRI for initial screening tool, but we do perform MRI before prostate biopsy, either in biopsy-naive patients or in previously negative biopsy patients. So how do we do biopsy? Remember, we do not biopsy every single patient that come in with elevated PSA. We will need, at the risk factor, look for any signs and symptoms that's causing the elevated PSA. And it's not convincing, we usually repeat the PSA after a few weeks. Ideally, in the same lab using the same assay, and there should be no recent ejaculation, manipulation, or even urinary tract infection. Then the PSA, if it still persistently rise, then there's a chance that this patient would need a biopsy. So at this moment, we have two types of biopsy, either the transrectal ultrasound guided biopsy, as you see the picture at the top, as well as the transperineal biopsy, which is the picture at the bottom. So the decision on the biopsy depends on the availability of the types of biopsy, as well as the risk and the location of the potential prostate cancer. So when we send the biopsy for pathology, usually it will be prostate adenocarcinoma. Rarely we will have some other forms of neuroendocrine tumor or leiomyosarcoma. So the Gleason score is used specifically for prostate adeno-CA, and usually if you look, it's got two scores, right? The first will be the most extensive, and the second score will be the second most extensive. If only one pattern is seen, the score will be double. For example, if you only see pattern 4, then it will be 4 plus 4. In 2014, they make it simpler by the International Society of Urological Pathology to grade 1, 2, 3, 4, and 5, where grade 1 will be clinically insignificant cancer, while grade 2, 3, 4, and 5 will be clinically significant cancer. Finally, based on the PSA, the Gleason score, as well as the local staging, we will determine this patient will be either a low-risk patient, intermediate-risk patient, and high-risk patient. And based on this will be decided on the management. The management will be further discussed by the following speaker. After diagnosing a patient, so usually we would stage the patient, right? So we usually stage by T&M staging, T local staging, N as well as M staging. So how do we stage this patient? So for local staging, most of the time we use multiparametric MRI. It has good specificity to look for both the T3 as well as to look for lymph nodes, but the sensitivity is very poor. So as you can see, the yellow arrow on the right-hand corner, you can see that's the lymph node, while the local extension you can see on the red arrow on the left image. So MRI is useful for both biopsy and treatment planning for both intermediate and high-risk disease. Right. Next, the distance staging, which is the metastasis, we will usually do CT scan, which has good specificity but poor sensitivity for lymph node mets, but it's quite good for visceral mets, so we can look for lung and liver mets. And finally, we use technician bone scan, which has good sensitivity and specificity to look for bone metastasis. So these two are the most conventional imaging that we use at this moment and actually influence our patient management. Other imaging such as PET scan, choline PET, fluoride PET, diffusion-weighted whole body MRI, yes, variable specificity and sensitivity, and because of the cost involved, it's not widely used for staging. But something interesting is coming up. This is what we call a prostate-specific membrane antigen PET-CT, which is PSMA PET. Uses either gadolinium or fluoride radiotracer to attach to PSMA, which has very high specificity for prostate tissue. It has very good sensitivity and specificity for lymph node mets as well as bone mets. And there's actually less radiation exposure. So at this moment, it's in Australia, there are increasing use of PSMA to stage the patient. And this is a potential game changer in the future. So you probably can look out in this space in the future. Summary of evidence, for patients with intermediate and high-risk disease, usually we'll do conventional CT as well as bone scan. For low-risk patients, usually we don't have additional staging, imaging for staging purposes. All right. For summary, remember prostate cancer is common, although it's less common here in Asia. Screening must be according to the individualized risk-adapted strategy with adequate counseling. PSA is organ-specific, not cancer-specific. And remember, patients may have cancer even though they are asymptomatic or low PSA. And not all prostate cancer patients will require active treatment. Thank you. If there's any question, you can ask us during the Q&A later.